of time, I'll request Dr. Dinesh Talwar to please straight away go on to your talk. We'll, if time permits, have a little more discussion on all these wonderful cases at the end. Dr. Dinesh Talwar on winds of change in PDR management for 12 minutes, if possible, please.
So, yeah, so can you see my screen?
Yeah, seeing your screen, yeah. Full screen, please. Yeah.
Okay, so this is my disclaimer, and so let's come to this. Why, basically there has been a paradigm shift based on this understanding of the role of angiogenesis in the development of proliferative diabetic retinopathy. We all know angiogenesis, the development of new vessels originating from pre-existing ones, but these are abnormal vessels. And these growth factors activate the receptors on the endothelial cells, and once activated, the endothelial cells release proteases, degrade the basement membrane, finally allow these endothelial cells to leave the original periparental wall, and then they proliferate and cause tube formations and cause these abnormal abnormal vessels to form. And the pivotal thing in this whole thing is the vascular endothelial growth factor, which is both a specific endothelial mitogen as well as a vascular permeability factor. Note that. The important thing is that it can account for both proliferative and vasopermeability changes in the course of PDR. Now, we already know that there are high levels of VEGF in patients with established PDR, and they get normalized with laser photocoagulation. We also know that you can prevent the development of a proliferative stage in mice models of ischemic retinopathy by blocking the VEGF action. And then finally, we do know that if you inject VEGF, you can cause iris neovascularization in primates. See, the important thing is that intravitreal injection of VEGF in primate eyes can actually cause intraretinal hemorrhages, retinal edema, venous bleeding, microaneurysms. Now, this is important because this is the basis of this can be used as the basis of our explanation of diabetic retinopathy regression following anti-VEGF agents. So this is important to keep a note of, right? So now, is PDR really as much of an issue as we are trying to make it out to be? Well, the fact is that if you look at it, though diabetic macular edema is 5 times more common than PDR-related blindness, but what DME causes is moderate vision loss, and what PDR causes is severe vision loss. And the number of cases is not less, almost 17 million, as opposed to 20 million of DME. So we have huge number of cases that need to be tackled. What is the current technique? The current technique is PRP. We all know that, and it works very well by reducing oxygen requirement. And that causes destruction of highly metabolic outer retinal cells, improves the retinal oxygenation from the choroidal circulation, and decreases the VEGF production due to the destruction of the hypoxic cells. So all three together work together. Now, if it's so good, then why are we looking for alternatives? Then the fact is that we know PRP can cause a decrease in visual acuity because of macular occurrence, macular edema occurring or worsening, can cause peripheral vision loss, sometimes rarely cause effusions, and it is painful. Most importantly, supplemental laser treatment could be needed again, and you could have disease progression requiring vitrectomy despite adequate treatment in around 5% of patients. So the protocol S actually evaluated the effectiveness of ranibizumab compared to PRP in patients with PDR. In this one group of patients was randomized to receive ranibizumab monthly for 3 injections. At month 4, they were evaluated again to see whether the neovascularization had recovered. And if it was still present, additional injections were given. And then at month 6, if onwards, injections were given as required. And if no neovascularization was there, it was not given. Or if it had reached a stable level, then also no injections were given. Now, what did we get in the protocol S? What we got was that there were better visual outcomes, less visual field loss, most important, fewer vitrectomies, and lesser development of center involving DME in the ranibizumab group. What was the advantage of PRP? It wasn't without advantages. Fewer visits, fewer injections, greater cost effectiveness, especially in eyes without DME. But more than half the patients in the PRP group needed supplemental laser during the first 2 years of surgery. The other important thing was the mild difference also in the chance of worsening, which was slightly more in the PRP treated eyes as compared to ranibizumab. At 5 years, the results were similar. The visual results were not different. The difference in patients who had no DME at baseline, there was actually no difference in visual acuity also. And that mean changes in visual acuity in patients with DME. Now, in those groups, there was initial better results that disappeared in 5 years. Visual preservation, the initial greater difference began to decrease at 2 years, and by 5 years, it was much lesser. But there was a very big concern, and that is of the number of patients lost to follow-up. 1/3 of the patients were lost to follow-up, and despite the inherent destructive nature of PRP, the patients reported more or less similar outcomes. Now, what is more important? In patients without DME, 7 injections were required in the first year and 10 in 2 years. In patients who had DME, 9 injections in the first year, 14 in the first 2 years. And as opposed to that, now patients who had PRP along with the injections, 5 injections in the first year, 9 in the second year. Now, to my mind, it seems to me that PRP may actually decrease the need for anti-VEGF treatment in the presence of concomitant DME. So the main advantage, it seems to be in the peripheral field peripheral field preservation. However, even this, there's actually been a study from UK which said 88% of patients who had a PRP could pass the driving test with adequate binocular vision fields. So it's not such a big issue either. The main difference, it seems, is in the lower rates of development of DME in the ranibizumab group compared to PRP in eyes which had no DME at baseline. And you can see that difference is 22% versus 38% even at 5 years. The other important was that many of these patients improved over time in terms of the diabetic retinopathy stage. So you can see the improvement in 2 representative cases from ETDRS score of 71 to 35 in this case, and from 71 to 35 again in this case. So basically, you could have an improvement in the stage of diabetic. Complications were more in the PRP group, and that's what was surprising to me. The number of cases requiring vitrectomy were much higher, 15% versus 4% in the ranibizumab group. So, but the basic fear, there is a danger of poor treatment adherence to anti-VEGF treatment in patients in a study in which 13 eyes of 12 patients who had their treatment interrupted for around 12 months. They came back with vitreous hemorrhage, neovascular glaucoma, and traction detachment, and more than 50% of the eyes ended up with visual acuity of hand movement or worse. So you don't want that stage to come. So this is maybe the way to go, where PRP was compared with a combination of PRP with anti-VEGF, and there was significantly higher regression. At least 2 major studies have shown that, and then the Proteus study, which compared PRP plus ranibizumab to PRP in high-risk eyes, again showed a similar thing. So what you get is that if you do combination therapy, you probably get a better result than if you do just a PRP alone. The other, so somebody may say, well, why PRP versus combination? Why not monotherapy versus combination? So that was also done, and basically in the PRIDE study, what it showed was that at month 3, the regression was 66% in the ranibizumab group. It had not regressed in the PRP group, but again, it had regressed in the combination group. But if you see, at 12 months, again, the regression, some of the patients had got their neovascularization back in the ranibizumab group, much less in the combination group, and very little in the PRP group. The final lessons we got from the PRIDE study was you can get a recurrence following monotherapy. Laser may be a better choice for high-risk PDR, and the combined therapy seemed to give the most sustained results. So now, the important thing is this is for regression, but we're now looking for a stage beyond. Can we actually cause a regression of diabetic retinopathy? So people have now evaluated what happens to the diabetic retinopathy severity scale. And this has converted the initial 85 levels to 13 different levels of the DRSS score. And is it possible for us now to turn this entire clock back? Well, let's see. Yeah, so sorry. So when you review the RISE and RIDE study, that was found that a 2-step change in the DRSS score at 2 years could happen was there in 36% of ranibizumab addicted eyes. And this was best in the eyes at the highest risk of progression to PDR, that is severe, very severe at PDR. This change was maximum. So it seems that maybe we can do something. The VIVID and VISTA trials again showed something similar, that you could regress diabetic retinopathy. Protocol T also showed that this could be achieved with all anti-VEGF agents. And finally, the Panorama study also showed a 2-step improvement. There they used aflibercept and showed that 66 to 79% of patients had a 2-step improvement in the DRSS scores at week 52. So while this can happen, there's a little precaution to be kept. While the regression occurs, but the FA does not change the amount of non-perfusion. So therefore, I still believe the best option would be combined anti-VEGF therapy with PRP in the periphery. So how do we manage PDR cases? How would I like to manage them? If it's raised neovascularization, complete laser therapy. First, give anti-VEGF injections. If it's a flat neovascularization, I just need half a minute. If it's a flat neovascularization, anti-VEGF followed by laser soon after. And if you have neovascularization persistent after adequate laser, you can have VEGF inhibitors. What about the role of monotherapy? I'm not going to discuss these individual cases and just tell you now what we believe about monotherapy. I believe monotherapy is something that we should only do after counseling the patient about the need for 14 injections or more in 2 years, with the possibility of more later, need for regular follow-up without a break, and the risk of retinal traction detachment requiring surgery if you do not do a regular follow-up. It's like catching a tiger by the tail. You've caught it, never leave it. You don't leave it, you're safe. You leave it, and you may end up in trouble. Thank you. Of course, in a patient like this, anti-VEGF treatment as monotherapy would be contraindicated. So, ladies and gentlemen, I conclude by saying anti-VEGF therapies for PDR has a definite role. This judicious use is required, and it's not still clear the risk of how much is the risk of neovascularization in raised neovascular forms if you treat them with monotherapy. Thank you very much.
Thank you, Dr. Dinesh. I mean, that was a fantastic talk. I mean, I love the interpretations you made, especially from the PRIDE study. I think they are very valid and very important in the context of our